Well, good morning, everyone, or afternoon for some of us.
Yeah.
We have our two important people here. Jonathan is here, and Kyndal, welcome. I know you're going to be our presenter today, so we want to announce the ELO, the conference, obviously. I mean, all of you who are planning on going and those who are still deciding, we encourage you to attend. It's a great way to make connections, not only to learn, but also to have a feeling that, you know, you are not alone in the world doing this, and also form some friendships that I think are long lasting. So it's going to be in October 19th from 8 to 11. And the topic for the ELO for pediatrics is going to be on suicide. It Takes a Village is the title, and it's going to be diving into the collaborations with the community, schools, families, and all that is needed to do this work to prevent suicide and prevent kids from falling through the cracks. That we know Virna, who is here today, helped this team a lot. In one of the SIGs, she presented on, you know, how to create tracking systems and etc. So that's going to be the topic. And obviously we will have also a lot of wonderful presentations from some of you, I'm sure, and many others. So if you have any questions about the conference, I'm sure Jackie is going to post a lot of other information on the website if it's not there yet. And apologies that I haven't looked, Jackie, for the hotel information and all the other things. I know your schedule is going to be there soon as well.
Yeah, hotel registration, all that stuff. We're working on the ELOs and the plenary sessions and the concurrent sessions. That's almost finalized.
Very good. Thanks a lot. So the other announcement we have is about the Pediatric Integration Awards that are going to be offered for the first time this year. And if you have any body or any organization, team, individuals in mind that have done stellar work, working in integration for pediatric care, whether it is innovation or working towards equity, anything related to integrated care in pediatrics, we welcome nominees. We have to give the award, and we want to be, you know, expanding that to you, to your teams, and anyone that you have in mind. It's not something that we want to do as a leadership team only. We want the participants and the members of this group to be in the loop and propose nominees. So feel free to reach out and do that. So for today's topic, we have LGBTQ plus, I always miss one of the letters, so I apologize. Health and integrated care. And our presenter today is going to be Kyndal Grammer. She's already here with us in the call. And she's an intern with Matthew Tolliver, who was our SIG co-chair for 2 years. And she's in East Tennessee University and Health Pediatrics, I think is the name of the clinic, correct? So I would love for you, Kyndal, if you have screen sharing capabilities, just to put your presentation and start. And then we will follow with Jonathan with the research corner presenting some research about this.
Alrighty. You may be seeing my dog as I pull up these slides, but that is Copper.
Good.
Alrighty. So I'm very excited to be sharing this little project with you all today. Again, my name is Kyndal Grammer, and I am a clinical psychology doctoral candidate at East Tennessee State University. And as part of my training, I work as a behavioral health consultant with Dr. Tolliver at ETSU Pediatrics. So I'm here today to share with you all the results from a little QI project that I initiated in our pediatric primary care clinic which is located in northeastern Tennessee. And to preface, in Tennessee right now, care of sexual and gender diverse youth is at the forefront of political controversy. So a little background, gender diverse and sexual minority adolescents are more likely than their peers to experience stigma in the healthcare environment. LGBTQ+ teens, like all teens, require affirming and inclusive care by providers to efficiently and effectively treat mental and physical health. Pediatricians are often the first line healthcare contacts for adolescents who are developing their sexual and gender identities. However, the current literature suggests that pediatricians have limited knowledge regarding LGBTQ+ issues and often don't address sexual or gender identity during their interactions with adolescent patients. The American Academy of Pediatrics has recognized the effects of heterosexism and cisgenderism on health disparities and engagement with health risk behaviors. So to combat these disparities, the AAP encourages creating a welcoming atmosphere, improving office systems, and striving to create an overall positive experience for LGBTQ+ patients and their families. So, given this, I was interested in exploring how providers at our clinic were engaging with our LGBTQ+ youth, especially given our substantially rural patient population. Ultimately, I wanted to identify some areas for intervention to improve quality of care. I developed a roughly 10-minute survey for resident physicians to evaluate their knowledge, behaviors, and attitudes related to the care of our LGBTQ+ teens. And so 24 residents were invited to participate in this survey. 2 started and didn't finish it. So the final sample consists of 15 resident physicians. The residents were asked how much of your clinic time is spent seeing adolescent patients, and of the 15 who responded, roughly a fourth of the patient population were adolescents, but that ranged from 10% to 50%. Jumping into the data, 100% of our sample reported asking their adolescent patients about sexual orientation. When asked how much of a priority is it for you to ask about sexual orientation, the majority reported discussion of this topic to be high priority or essential. And then participants were asked, what percentage of your adolescent well-child checks are you asking about sexual orientation? And as you can see, responses range between 40 to 100%, but with the majority asking more times than not. Next questions are regarding gender identity. So about 75% of our sample reported that they asked their adolescent patients about gender identity. And then again, when asked about priority, just over a third of our sample reported discussion of gender identity being high priority or essential, with the majority saying falling in this medium priority range. And then of the participants who said, yes, we do ask about gender identity, I followed up with that, what percentage of your adolescent well-child checks are you asking? And here we see a range from 0% to 90%. Next, I asked some questions about asking about patient pronouns. So 40% of our sample report asking about patient pronouns. And pronouns had the most folks reporting no and not considered asking about them. And then when asked about priority, the majority reported that this was a medium priority, but we also had a wide range of ratings of priority. And again, of those who said yes, they are asking, the responses ranged from 40% of adolescent well-child checks to 90% of adolescent well-child checks. And then 100% of our sample reported asking their adolescent patients for the name that they go by. However, this result should be interpreted with some caution, as I'll explain in just a little bit. But Similarly, when asked about how much of a priority it is, we had the majority of folks saying that this was high priority or essential. And then again, what percentage of well child checks are you asking for the name that they go by? We had a lot of people say 100%, but we still had some variability. And so these data right here explain why the data should be interpreted cautiously. While we provided definitions between legal name and name patients go by in the survey, we're wondering how residents interpreted this question, considering the lowest age reported is 3 years old. For example, asking your patients, are you insert name from chart, which is often the legal name, is different than asking, what would you like me to call you, or what name do you go by? We asked our residents, how would you rate your knowledge of the specific health needs for LGBTQ+ patients? And as you can see, the majority of our sample fall within this average range from 4 to 6, but there is a slight positive skew here. Next, we ask, how would you rate your motivation in learning more about treating the unique health needs of LGBTQ+ patients? And the majority reported higher levels of motivation, which is encouraging given that we're hoping to intervene. And then we asked, how much of a priority is it for you to learn more about treating the unique needs of our LGBTQ+ patients? And here you see there's a relatively normal distribution. However, there are more folks reporting in this higher range category than these lower priorities. And then when thinking about implementing interventions, we wanted to know what residents perceive that would help them increase their confidence working with our LGBTQ+ teams. And so we had these 3 items in a checklist format, so they weren't mutually exclusive. 9 participants said knowing more about terminology would increase their confidence. 8 said knowing more about AAP guidelines and guidance. And then 13 out of our 15 participants said learning more about how Tennessee laws impact their role as a physician regarding care of our LGBTQ+ teens would increase their confidence. So that was a pretty substantial number. And I've just thrown these up here just for folks to skim over. But one of the unique parts of this survey, in my opinion, is the inclusion of AAP recommendations. We listed each of these recommendations and asked our residents to rate the importance of adhering to them, as well as the frequency of them following each of the recommendations. And we used Likert scales for these items. We also asked about barriers that get in the way of following the AAP recommendations. And so residents most commonly reported that the recommendations were moderately important and that they occasionally / sometimes follow them. And they most commonly reported that barriers of time, difficulty breaking habits of language, and forgetting got in the way of engaging in these recommendations. So that's where we're at this point. Next steps, we're looking at presenting at a couple of conferences, partnering with some of the residents who have an interest in our LGBTQ+ teens to then develop interventions for our resident training program.
Excellent. Thank you so much, Kyndal, for that great presentation and for the research. I wonder if anyone has any questions for Kyndal? Anyone doing this work that you found something that you think you're going to borrow from what she has done? I certainly will. I love what you did, so I will make sure I disseminate it in my organization, which is one of the things that I like about the SIG, you know, that ideas can just support so many other teams.
Kyndal, were the results what you thought, and what kind of interventions would you consider kind of based on this, or would you consider other clinics who might be interested in this topic, kind of what could they do to promote LGBTQ plus health for their adolescent populations?
So because I work alongside the residents, I kind of saw how they were engaging with our teens already. I wasn't super surprised with any of the results in particular. I thought it was really interesting looking at just the AAP guidelines and how those differ from the APA guidelines and how we as psychologists kind of live in the world. But for interventions, I think that is where I'm getting really tripped up, because there are lots of great interventions that exist. However, most of them were conducted and validated in areas like that the political climate's a little different, and therefore the area that they're working in and the number of folks and their comfortability levels are already a little heightened. And so that was why we asked some scaling questions in our survey, was to try and get almost like at some stages of change for our residents to see where are we at. If our folks are really motivated in learning more about treating specific health needs of LGBTQ plus teens, that intervention is going to look much different than folks that are not motivated, don't know any of the terminology of the lingo, that kind of thing. So for our clinic, I think it's going to be really important to collaborate with those residents who want to join this project to really see from their perspective what would be most helpful, especially because not all of our residents work with teens that often. And so what are the key points that need to get really woven into the training? There are also some electronic medical record interventions that I'm interested in, such as right now, we don't have a system for putting in gender identity, sexual orientation names patients go by. Rather, it's just little alerts in the charts. Some have them, some don't. It's a little chaotic. So I think streamlining that process is going to be helpful, as well as just updating our patient paperwork to move away from the lingo of preferred name, preferred pronouns, and make it a little bit more objective and routine on checking in about those kinds of things, especially for adolescents whose identities are fluid and can move back and forth and that kind of thing. But I definitely think just being willing to have these conversations with teens and normalizing asking, normalizing displaying your own pronouns, wearing some kind of symbol of inclusivity are really simple first line steps of showing that your practice is a safe place for them to talk about these concerns.
Bill did a great job with that project. And I think it's another plug too for, just being able to do some QI and research in a primary care setting, even if you're a clinician in that setting. I think, Kyndal, you pulled this off just in a couple months, kind of from the start to the data analysis part. So that was really cool. And since then, we had 2 residents who approached us and who were interested in helping with a poster for the project. So one of the other things was, could it be a resident-led initiative too, where they can, 3rd-year pediatric residents are part of the teachers or the leaders for an organizational intervention like that. But yeah, great work.
Yes. And I love the comment from Carly that it's an intervention in itself to do this assessment. So great work.
Over the last few years, I'm a doctoral student in a PhD program, so I've been a part of a bunch of practicums, pediatrics, counseling centers. We usually have some kind of presentation, then we have some kind of discussion after, but I think it just gets you to really reflect on that. And Kyndal, I thought your presentation really did that. You asked these questions that, I've asked myself, does this practicum or department do this well? And I think it just can lead to facilitate this kind of awareness of the issue or how to better address all these problems. So great work. And congratulations conducting research within your department. I know how hard that can be. So that's awesome.
Thank you. I definitely attribute that to the support of Dr. Tolliver because he has been a very vital component of this research.
Any questions for Kyndal? Any other reflections? You can use the chat if you can't unmute. I was going to ask you something about the climate because you obviously mentioned the political aspect of it, and is that something you guys saw permeating in the organization at any level, including this project of yours? Was there anything to consider that was brought up by that political environment?
I think anecdotally, I had been hearing more of our teens saying to me that like it is scary to live in Tennessee right now, being trans, being queer. And so that was something that I think, because it is a topic that is being so politicized and folks feel very strongly one way or another about it, it was starting to become more of an issue for our residents of just like, how do I navigate this? I don't know what to do. Let's just pull the BHC because I don't know how to have these conversations. And so that I think is something that has come just from what I've noticed in clinic. And then I also think that us being able to throw in like, do you guys even know what's happening with Tennessee right now? And are you familiar with the laws that are affecting your role? I think that's something that's going to be helpful too in helping approach these conversations rather than just avoid, because folks are worried about losing their licensure and worried about the repercussions that could occur on them. And Dr. Tolliver, I'm sure with you being in the practice longer, you may have some insight into that too.
I don't think we had any like pressure from the university or the department to change or do anything differently with the survey. I think what we just tried to be really intentional about making it totally anonymous. I mean, we're kind of a smaller program anyway, so we set up the survey in a way where we kind of put some language where we're talking about how we respect everybody's views, and we're not necessarily even trying to change anybody's views. It's just we want to understand where people at and say, here are the AAP guidelines. What do you think about them? Where can we be? But we did a lot to try to make sure that people could, complete the survey anonymously. And I think I think the political climate, maybe that was like a more important thing in particular, right? Because we didn't want anyone to feel like, oh, my opinion about this leaked or got out or something when I didn't want it to. So I think it's something to think about if you're surveying, if you're in a smaller program, you're trying to do internal kind of QI stuff anyway, is how do you protect people's confidentiality while you're doing that? And explain the rationale for why you're asking them these questions.
Definitely, the aspect of safety is key for this one. Are others on the call experiencing this climate and have that affected in any way the way you approach this topic? In our organization, well, in the hospital in Boston Children's, we have been receiving some communications to the staff, strongly asserting the views for respect for trans health and following threats and incidents that have happened to the hospital. So in a way, it's a reassuring experience to hear the backup of the organization and even the leadership in topics like this. But of course, we don't have the political climate that we can compare to what you're experiencing, guys. But I think this is very important work that you're doing, especially in that climate. And it looks like you managed to make people feel safe about sharing their perceptions and opinions about it. It's great work. So if no one has questions or comments, we can move on and have Jonathan present some of the research on this. Are you ready, Jonathan?
Yes, let me share my screen. Okay, can everybody see this?
Yes.
So I'll be sharing with you all some data from the Trevor Project. The Trevor Project, for those of you that don't know, it's an American nonprofit organization founded in 1998. I actually saw it pop up quite a bit across the literature, so I thought that was nice to see. They create these research briefs from time to time, and let's just get into it. So previous research, or this research brief they put out, showed that LGBTQ youth are coming out about their sexual orientation at younger ages. And the data broadly across LGBTQ youth found that those who came out about their sexual orientation before age 13 reported higher rates of attempting suicide over the past year and experiencing victimization. However, those youth who came out of their sexual orientation before age 13 but had high family support reported lower rates of attempting suicide in the past year. So this March 2023 research brief that we'll go through looked at more specifically transgender non-binary youth, and to see how gender identity factored into these outcomes. So again, it's the same data set they collected data between September and December of 2021. About 34,000 LGBTQ young people were recruited through targeted ads on social media. And they asked participants, the first age they began to think about being transgender and or non-binary, as well as the first age they came out to others about their gender identity. And questions related to suicide risk came from the Centers for Disease Control and Prevention's Youth Risk Behavior Survey. So let's see here. So transgender non-binary youth reported coming out about their gender identity at younger ages. If you look, and they separated into two categories, ages 13 to 17, ages 18 to 24. So those that were 13 to 20, those that were 13 to 17, the average age of coming out was 14, with 16% coming out before the age of 13. When you look at the age 18 to 24 category, the average age was 18, with 3% coming out before the age of 13. And overall, out of the sample, 11% of the sample came out before age 13. Now looking at suicide risk, transgender non-binary youth who came out before age 13 had increased odds of suicide risk. 62% considered suicide, 29% attempted suicide. Looking now at victimization, transgender non-binary youth who came out before age 13 and experienced victimization reported higher rates of attempted suicide than those who had not. Those who attempted suicide, 38% experienced physically threatened or were physically threatened or harmed, or 31% experienced discrimination. Now looking at family support and suicide risk, similar to the sexual orientation research, transgender non-binary youth who came out before age 13 but had high family support reported lower rates of attempting suicide at 17% compared to those with low or moderate 30%. And yeah, I think that let me make sure I wrote this. Yeah, also those with high family support were low rates of considering suicide. Yes, so they considered suicide less at 44% versus 67%. So what are all the implications of this? Basically, transgender non-binary youth data matched very similar to the LGBTQ data, in that people are coming out at younger ages and again share similar trends with sexual orientation outness. As we saw, family support was associated with lower suicide risk among these youth who came before age 13. And again, this highlights that unique, important role that families can play in supporting their children. More work needs to be done to figure out how to help these children navigate these physical and emotional safety problems that could occur. And here is the two research briefs, the one I mentioned and this one. And all of this obviously has a pretty big family implication, that families can be really impactful. I think it kind of speaks to us that as providers, clinicians, physicians, that there's certain ways of being gender affirming that can more than likely significantly impact the lives of the children we see. Thank you.
Thank you so much, Jonathan. Great work. How wonderful how it connects with the ecological safety piece. Continue the conversation with that. Kyndal, you raised your hand. Go ahead.
I was just clapping.
Thank you. So yeah, I think Kyndal, to your point, I think, I'll just speak from I had a diversity training in my pediatric clinic this year in a counseling center, and it kind of came down to just being, using appropriate pronouns, asking all these questions. And so I think as providers or clinicians, if we can do those kinds of things, and all the APA recommendations you provided, I think those are the steps that we can take. Does anyone else have some ideas about how maybe we can be better or more mindful of this ongoing situation?
I think we have a quiet audience today. I put on the chat the toolkit from Fenway for pediatric care, which I think is really good. I don't know if you guys are familiar with it or not, but if not, you can check it out.
I was wondering, and I didn't hear in that data anything about overdoses, and I don't know if they had, I'm familiar with Trevor Project, if they were going to do something around the unintentional and intentional overdoses in that population. And I don't know if you saw anything called out when you were sort of looking at some of the research, but I know that the suicide by overdoses has significantly increased in that population. So just wondering if you saw anything around that.
I did not, but however, they have so much information, like you said, I'm sure that could be found. But yeah, no, that's a great, they just have a wealth of information, and but yeah, no, I can see that being the case.
Yeah, I'll have to look it up. Thank you. Just sort of wondering. Sorry, didn't want to take us down a rabbit hole.
Thank you, Virna. Kyndal, maybe you can tell us what got you inspired and what do you recommend for us, other members on the call that might have residents or interns. What can we do to get our residents or interns inspired the way you did? And just your tips and your journey, perhaps, if you feel comfortable sharing some of that.
I think with our program being so small, we are pretty tight knit too, which was really helpful with this. They see me as just one of the trainees in the program and supporting not only research from one of our fellow colleagues is going down this road, but also giving them some autonomy and choosing what their residency training might look like was also one of the ways that we framed this project to them. I think that really, like Dr. Tolliver said, saying that this is really to support you all. We're asking these questions with purpose and just trying to make your experience better was helpful. I obviously, in the back of my mind, had yes, I want to improve patient care at that level too, but really emphasizing to the residents, this is something that is really important not only to you, but also just for your work, and how can we make this an easier conversation for you to have too. And I think there's just a lot of the residents are seeing all kinds of different things. This is just one small piece of the puzzle, but I think there are a lot of common factors that exist within how we talk about these things with LGBTQ plus teens to just teens who are exploring sex and risky sexual behaviors and who are at risk of suicide and those types of things. I think for our folks, we could sell it a little bit more. But one of the questions I asked in the survey was like, what prompts you to ask about sexual orientation, gender identity? And a lot of folks for sexual orientation said risky sex behaviors. And that was something that I think with like suicidalities, like we know suicidality is higher for folks who identify as sexual or gender diverse. And so trying to just show the importance of asking these questions and how that can be mapped on to kind of like the decision tree that a lot of our residents work from. So I think from the get-go, we really tried to say, how can we show the residents that this is worth discussing and being a little uncomfortable with and making those moves. But I'm still trying to figure out ways to connect even more to try and bump up the confidence and knowledge and engagement in the AAP guidelines for LGBTQ plus adolescents.
Thank you. I love also your approach about universal screening versus, oh, this looks like a person, I should be asking the pronouns. Yeah, so I like that. Jonathan, is there anything that surprised you from the reading of the Trevor Project data?
Yeah, I mean, I think it's, I think we understand these, that LGBTQ individuals are more likely to unfortunately have these outcomes. It was surprising to me how the generations are getting younger and younger before the age of 13. And I think it just kind of brings attention to this idea how mindful we have to be as providers to these children. Not that we never shouldn't have been, but just that it is a very serious thing. And I think if we can take these small steps, looking at family support, for example, if a child or adolescent feel comfortable with their provider that they can confide in their sexual or gender identity, that could have significant impacts, not only their health care, but potentially their life. So I think that's a really important thing that, and I mean, we talk about all the suicide risk, but when you actually look at the data like this, it's right there in front of you.
And and you're bringing up a point that is very connected to the political discourse as well, because, when we have decisions being made by politicians about health versus research like the one you presented that can go really wrong. And your data actually speaks about why early is important rather than delaying decisions about care, like is happening in many states. So I think it's super important to know your research and make decisions based on that.
I have a 24-year-old son who he was out to us before he was 10 and out to his doctor, his pediatrician, when he was maybe 12. And it was interesting because as he got older, maybe around 12 or so, he started going into the appointments by himself and I would stay outside. And then maybe around 16 or so, he's like, Mom, I want to keep, and it was a very, great pediatrician. He never didn't like the pediatrician, but he's like, he doesn't know at all about PrEP. And he's like, I'm trying to teach myself about these things before it becomes an issue. And he doesn't know. And I thought he's like, I told him about it and he said he's going to learn more about it. But I thought that was interesting, just that like, here's a kid who's like really on it. And, I know he didn't start dating till later, but it was just kind of interesting that like the doctor said all the right things, but didn't have all the right knowledge because he probably didn't at that point know too many people in his practice or having conversations openly at that age. So
I really appreciate your comment and coming with that example. I how much do patients screen us?
yeah,
As well, it's like by directional. They know who they are dealing with. I have one of the pediatricians working in our group also told me that once she decided to put the LGBTQ plus flag in her in the door of her office. Suddenly a lot of kids would talk to her about that because, they just making it so friendly. But of course, the piece of the knowledge has to follow, not only your attitude, but knowing what you're talking about. So,
Right. Well, now, he's a young adult living in New York City, and he sought out a physician who was gay because he said, I feel like he understands my
Right.
issues more than, so it's been an interesting journey for me just to learn. And as my husband's a physician, my son is a physician, another son, different son. So it was just kind of interesting how it's affected all of us. And been like, or even I have my flag up in the backyard. But last year in July, when my son came to visit, and I said, "Oh, I guess Pride, June is over. I guess I should take my flag down." He's like, "No, Mom, you should keep it up all year long because you're an ally all year long, not just in June." So sure enough, I have my flag up all year long, and I have like 4 of them. So when one wears out, the next one goes out.
You get a point.
I mean, just anecdotally, I wear on my name tag this little rainbow pin type thing, and I can't tell you how many I've been in a visit where I'll see the teenager and adolescent or the teenager and the parent together, and then I'll meet with the adolescent, and then they'll make a comment like, "Hey, I like your pin," or something like that. And it kind of just opens up conversation in a way that I don't think it would have probably if I hadn't worn it. So I think those I think those youth are looking for these signs, right? Of the little rainbow pin or flag in the office, things like that signal a whole lot in a world, I think, especially in places like Tennessee, where you have to be maybe even more cautious about how open you are. And it's even you're looking for people in places to be able to disclose to in a safe way.
Yeah, that's what my son said. Mom, I knew where every flag was, every sign that somebody was an ally. It clicked in my head. I recognized those businesses and everything. So and that was when he was young. So I was like, wow, that's good lesson to me. Actually, my t-shirt is
Nice. And it touches on the trauma-informed care or trauma-informed practices. I think is a big component of that. I mean, it all goes back to what we said at the beginning on the safety piece, for starters, right? Kyndal, are you going to come to the conference and meet all of us in person?
I don't think I'm going to be able to. I'm starting my internship year in July, so I feel like October is still going to be a little chaotic for me.
I get it. Susan, Carly, Virna, Jackie, David, Jonathan, Matthew. Any other questions, comments, feedback, or inspiration?
No, just that, like I said, conference registration is open, and we're continuing to upload information as we have it. And the conference schedule should be close to done. We just need a couple more eyes to look at it. There's a lot of pediatric sessions, so that's kind of exciting. So
I'm glad to hear that there's good pediatrics. I'm hoping I can make it. I have my play therapy conference in Palm Springs, and last year the same thing happened. They're like, one ends, I have one day, and then the next one starts, and it was really difficult doing 2 back to back like that, and then not seeing patients for a week and a half. So I'm gonna try. This year play therapy's first. Last year it was reverse. You guys were first. So I'm gonna try, but play therapy I've already paid for, so that I'm committed to. I know.
okay. Well,
Go ahead, Jackie.
Oh no, I was going to say we do also have 1-day registrations, if that helps. So
I also want to, call attention on the webinar that Susan and I did together last week or 2 weeks ago on play therapy. If you want to know what Susan does and the wonderful practical tips she offers to use play therapy in integrated settings, just go check it out on the website. And also for all of you, as always, the content of this is going to be available, both the recording, but also the slides for any of you. So It will take a while because we have to, rely on the CFHA wonderful people who post the things there and edit whatever needs to be edited. But I think a week or so. So
Take
thank
care.
you all, and thank you so much, Kyndal. It was great having you, and good luck in the future. And I'll see you also.
Bye-bye.
Bye bye.